Hello, everyone. I'm Dr. Carmen Puliafito. I'm here today with Dr. Nadia Waheed, who is a professor at the Tufts University School of Medicine and a member of the retina faculty at the New England Eye Center. Also, I should say, one of the directors of the Boston Image Reading Center. Can't forget about that. Nadia, welcome to Retina Synthesis.
Thank you so much for having me today, Carmen. It's absolutely a pleasure to be here.
Yeah, it's great. It's great to have you. We've been wanting to have you on from the very, very beginning of our publication.
Thank you.
Today, we'd like to talk a little bit about microperimetry and its potential role in evaluating eyes with geographic atrophy. Can you tell the audience what microperimetry is and how it's done?
Absolutely. So microperimetry is a functional test of the retina. And it's nice because what happens is you project small stimuli onto the central retina, and patients respond by pressing a buzzer or and you look at their response, and you titrate up and down the light stimulus that's presented onto the fundus. That has a few advantages over traditional functional testing. One is that it's very closely mapped to the structure, so you can do structure-function correlation. The second piece is it doesn't just test the fovea, it tests an entire area, and you can map out how big of an area you want tested. And so it provides that granular structure-function correlation. Also, you can track, especially with the newer devices, you can track change in signal over time. So you can test patients repeatedly and follow up the same areas of the retina and see how they change, over a certain period of time. And I think those are the three big things that make it ideal for testing a disease such as geographic atrophy.
How long does the test take per eye?
So it's variable. I think that if you have a completely normal subject that they can generally do it depending on the density and the grid that you use, about 10 minutes per eye. I think it's longer if you test patients who have poor vision or poor fixation. And so typically we're looking at between 10 to 20 minutes per eye. So
the structural correlate, is it a fundus photograph, an autofluorescence image, an OCT? What is it?
So the structural correlate that you get from the device itself looks very much like a fundus photograph. It's a black and white fundus image. And of course, once you have that fundus image and the cross-correlated points, you can then go back and register with whatever other imaging modality you want to. But the one that comes out from the device itself is a fundus image.
Mm-hmm. So in one of the Apellis studies, microperimetry was used to assess eyes. And which one of those studies was it?
So it was in the OAKS trial.
In the OAKS trial.
Mm-hmm.
And you were involved with a study that was performed. Can you tell us about the study?
Absolutely. So it was a somewhat unique idea back, when Apellis was starting their phase 3 clinical trials, and they had gotten feedback from, especially the European regulators, saying that they would like to see some kind of a functional signal. And I think a lot of the emerging data seem to suggest that, unlike visual acuity, which is not a great way to follow patients with geographic atrophy, that's something that's, that has a structure function, kind of a mapping like microperimetry, maybe a good way to follow these patients. And to give credit where credit is due, a lot of phenomenal work coming out from Robin Geimer's lab, from Vas Sada's group around, microperimetry back when the OAK study was starting. And so the Apellis guys discussed it with us, and we thought that it may be forward thinking to integrate microperimetry into clinical trials of geographic atrophy. So in the OAK study, which was, as you know, a randomized controlled trial looking at pegcetacoplan in patients with geographic atrophy, and it tested every week pegcetacoplan, every other week, every month pegcetacoplan, every other month pegcetacoplan, and then an untreated control group. All of these patients were offered microperimetry, and microperimetry was integrated within the OAKS clinical study as one of the mandatory assessments, except for patients who, for some reason, could not complete the microperimetry assessment itself. And it was rolled across over 100 sites across, the U.S. and Europe, and was used to follow these patients up over time. And of course, the nice piece is that it's structurally registered from one visit to the other. The endpoints in microperimetry, because functional endpoints take longer to express and structural endpoints do, were assessed at a year and at 2 years, and really the microperimetry analysis was designed to be conducted at 2 years at the end of the study at that point.
And so, what were the findings?
So really interesting. What we saw, and what we expected to see, as with visual acuity, as with any other functional endpoint that kind of just looks at the entirety of the area, we don't see very nice separation between patients who are treated and untreated, just because when you're looking at just means or averages, they're scanning over a large area, and most of that area is occupied by geographic atrophy already, so it's dead zone. But one of the exploratory analysis that was conducted was one that was designed at the Boston Image Reading Center in collaboration with Eric Mold at MIT, looked at perilesional analysis. And what this analysis really does is it looks at the zone at risk in patients with geographic, which is a zone immediately surrounding the area of geographic atrophy into which we expect the geographic atrophy to grow. And when we looked at that zone at risk in these patients, we found that there was a very strong trend, very similar to what was happening in the structural data, that there was a very strong trend of separation between the untreated group and the treated groups. And we found that that trend tended to increase as time went by. So the trend was bigger, the separation, the differentiation between treated and untreated groups was greater at 24 months than it was at 12 months, which was greater than it was at 6 months. So really, encouraging functional data when you look at that zone at risk, at that region at risk, which is the perilesional zone of the geographic atrophy.
So what it really shows is that not only does the area of growth is diminished in the study, but the function of the preserved retina is evidence that the drug is working.
Absolutely. I mean, it shows what we had known all along, that if you can stop the photoreceptors and the RPE from degenerating, or if you can slow down the degeneration, that you will slow down functional loss in the areas in which you're slowing or stopping ellipsoid zone and retinal pigment epithelium loss. So I think very nice endorsement. And what was really interesting to me was how all the data pointed in the same direction and all the data was coherent. So the structural data obviously showed that over time you slow down growth of GA, but the functional data also showed that in an equivalent manner, you were also slowing down loss of function over time.
Yeah.
And so that was a really interesting piece, I think, around this data.
That's really terrific. Were you surprised?
I was not surprised, because we expected that, right? We always know, and we've known looking at OCT scans that, and patients have told us this, right? That as you lose more and more structure, that these patients are struggling more functional. I think what I was really delighted at was that we were able to craft an endpoint that really interrogates this functional decline and is able to show that differentiation. And, when we started the study, we knew that that would be the case, right? Just intellectually, that, it's coherent with what patients are complaining of, that if you really focus on the perilesional area, that you should be able to show that they're slowing down a functional loss. But I think the really exciting part was actually seeing it play out and actually seeing how, how similar it was to what we were seeing in the structural loss. So I won't say surprised, but really happy that we were able to pull this out, and that was exciting.
So in the study, did you study all the edges of all the islands of geographic atrophy?
Yeah, so that's a great question. And the answer is yes, we did, right? So we set 250 microns from the margin of the GA. And for multifocal lesions, that meant that it was 250 microns from the margins of each one of the GAs. So the computer program that had been generated at the Boston Image Reading Center, as I mentioned, with Yasin Alibai and Eric Mold, leading this drive, and special credit to Yassine, who was a very innovative thinker around this. The software that's designed creates 250 microns perimeter around all of the lesions, including the multiple lesions in multifocal GA lesions, and then looks at the entirety of that area. Yes.
Mm-hmm. So that's a very powerful study then.
We thought that the results were really powerful and interesting. Yes.
So back in the real world, how do you think microperimetry could be used by a clinician in examining eyes with geographic atrophy? Is there a way forward for that?
So I think that's a great question. I think microperimetry is not an easy test to do for these patients, especially patients who have poor fixation. And so I think as far as a clinical trial tool goes, that it's a great clinical trial tool to have. I don't think that it's something that we would routinely use in clinical practice. However, having said that, there are certain things that I think make it useful in clinical practice. For example, if over the long term you're following patients up, you don't necessarily need to do fancy analyses or a very complicated microperimetry protocol, but even just looking at their fixation area and looking at, BCEA, which is a measure of fixation stability on microperimetry, can sometimes tell us something that visual acuity alone cannot, which is that patients are having a harder and harder time staying focused, being able to read or track objects when they're driving, and can really show us how the disease progresses. I think in select cases where patients are complaining about some of these things, and that's not really evident when you look at their, fundus photographs or fundus autofluorescence, that microperimetry could have an important role to play in those patients to document that decline in function that happens with GA, and to show that, wow.
I suppose that if you had geographic atrophy that was threatening the fovea, you could study the edge that faces the fovea and look at that very carefully. Would that be reasonable?
You absolutely could, yes. And that's also the edge, of course, that gives you, the fixation stability. So both you would expect the individual stimuli the individual areas of the retina to decrease in their ability to see. You would also expect in these patients that edge that faces the fovea to become more and more fixationally unstable. And you could use that to document that a patient's vision was declining. My hope is that we have a relatively broad hand to treat patients who we think would be appropriate to treat with some of the newer medications that will get approved, because I think that's really what we need to be able to do. But of course, in situations where you might need to document that, I think microperimetry can be very useful.
Yeah, I mean, it's exciting. All the discussion of Derby and Oaks has really been around area, not about preservation of function. So I think this is a powerful argument that needs to be brought forward. So I hope this is published quickly.
I'm looking forward to that, and I hope that too. And I think there's a manuscript that's in preparation right now and getting ready to get submitted. So I really look forward to this.
Well, I know our listeners are going to be interested, and viewers are going to be interested in hearing about this. So Nadia, thanks so much for coming on board to Retina Synthesis. It's been a pleasure chatting with you.
Same, it's been lovely. Thank you so much, Karen.